need to let me know if you can see. Can you see that's where it says slideshow? Yeah,
Yes,
I'm just going to put it on the slideshow from the beginning. All right.
Yep.
Thank you. I'm so sorry.
You're right. It's all good. No stress
Can
at
you
all.
see it now? Because I'm on a dual screen. Can you see where it says slideshow? Yep.
Yes. Yeah.
Very good.
Yep.
All right. So apologies for being late. I'll stop apologizing now because it will be distracting. But thank you very much for inviting me to speak. And I know that maybe there's not heaps of paediatric palliative care nurses online, but I just think that some of the things that we talk about are definitely transferable. And I just also think that even though I work in a hospice setting usually, that a lot of the things that I talk about actually are transferable to families or homes. And so a lot of the things I talk about will be, it's kind of home-based palliative care, if that makes sense. I thought I'd look at symptoms that are commonly seen, but then apply it to 2 case studies. So hopefully that will be worth it for you. And we can have time hopefully for questions at the end, but certainly if people want to chat as we go through them, that's absolutely fine. I've got 2 case studies to share with you as well. So paediatric palliative care, as you can see on the screen, it's a lot of words. Basically, it's palliative care for children and young people with life-limiting conditions, and is an active and total approach to care from the point of diagnosis or recognition through the child's life and death and beyond. And I think that's where it differs a lot to, or not maybe a lot, but it differs to adult pal care in being that we can have children under palliative care banner who are with us for years and years and years. Sometimes these children are diagnosed around birth and they're expected to die before they're 18, but not necessarily really quickly. What we find in the hospice is we take children, so I work in the Hummingbird House, which is the children's hospice in Brisbane, is we actually take children who we wouldn't be surprised if they die within 2 years. So we are kind of a little bit narrow, and that's really just because of capacity. This is my favourite quote though. So this is by a young man called Matty Stepanek, who has now unfortunately died. He said that paediatric palliative care no longer means paediatric palliative care no longer means helping children die well. It means helping children and their families to live well. And when time is uncertain, and when the time is certain, to help them die gently. So paediatric palliative care no longer means helping children die well. It means helping children and their families to live well. And when the time is certain, to help them die gently. So the Together for Short Lives, which is the first quote, that is what we base quite a lot of our work on, and that's based from the UK. It's an organisation that really has standards for paediatric palliative care, and it's used fairly internationally, definitely across the UK.
Andy,
yeah.
Oh, sorry to interrupt you.
Yeah.
A couple of people have said that the audio keeps cutting out.
Yeah, and I've just bought, one of the reasons why I say I've just bought a Wi-Fi extender. I wanted to try without the headphones.
Do you want to try it and see if it works better?
I can try, yeah, and then just let me know.
And then possibly if everybody else can make sure that.
Can you hear me?
Yeah, thanks. All right, let's try that and see if it works better. Sorry to interrupt you.
Can you hear me now?
Yeah, that's better, I think.
All right, let me just try it. I have bought a Wi-Fi extender because I work in the corner of my house and it just doesn't stretch this far. All right, and I apologise because I talk quickly as well, so please tell me to slow down.
Is that better?
Yeah, good. All right, okay. Sorry if there's any background noise then, because I am at home. All right, so I just wanted to share this story with you. So I use extensively what is known as the Green Book, and this is where I get most of my information in regards to pharmacological management of children at end of life. What I'm going to talk about during these sessions are actually symptoms at end of life. So whilst I acknowledge that paediatric palliative care really is, like a long-term care of the family, for the benefit of this group, and really to concentrate on what I do specifically in the hospice, I'm going to look at symptoms at end of life. I want to share this with you. It is we use it nationally, so we use it all across Australia and New Zealand. So it's a really helpful book. It's available. It's actually just been updated, so it's not commonly available, as in new copies are not available. And we're just updating it over the next year or two. but it's a really valuable resource. And if anybody really does want one, I could see if I can get a hold of a few copies, but it is being updated. All right, so these are the common symptoms that we see at end of life with children, and I actually don't think they're dissimilar to what we would see with adults who are dying. So common symptoms are neurological, so fatigue, confusion, loss of function, and they often lose the swallow, especially towards the very end of the life on the terminal. We sometimes see pain. I see pain particularly in children with cancer. So, children with a brain tumor will often have headaches, etc. Or, if they've got a big on the spine or in the belly, in the bones, then we often see pain. Children with neurological conditions, we sometimes will see pain caused by dystonia, but I feel like it's so cardiac, so sometimes the children can get poor circulation, they can be tachycardic or bradycardic towards the end of life. Really common, we see respiratory issues, so colour changes, that can also be cardiac from a respiratory point of view. When children are having apnea, you can see quite marked colour change, so pale or blue or purple, and then dyspnea, which is common across both palliative care in adults and children, and then apneas. And so I have seen a baby not breathe for 30 minutes, which is absolutely astonishing. I'd never seen that before I worked in pal care, but you think, oh my goodness, have they actually died? When you listen, they've got a very, very faint, weak heartbeat, and then they might take another beat. That can be really concerning for families, and I'm always very slow to call time of death on a little tiny baby because it's tricky all the time. Often what we see as well, and this is one of the first things commonly, is feed intolerance, so problems with gut, nausea, vomiting, constipation. That could be just because the gut's slowed down, but of course it could be drugs, and then sometimes diarrhea. And then the existential things, which is common across both, but certainly fear, anxiety, depression, and existential pain. So fear of dying, fear of the unknown, fear of leaving the family and how the family going to cope without them. So all of these things happen at end of life. I thought I'd introduce two families so that we can talk through these common symptoms and how we manage them in the hospice setting. I just wanted to say up front that I do use real names, so these are not pseudonyms, and it's a really deliberate choice on why I do that. And what families tell us, so I've got permission to share, and I've got permission to share all the photographs in this presentation, but what families tell us often is that people are afraid to use the children's names once they have died, for fear, many reasons, but one is for fear of upsetting the family, and reminding them that the child's died, and of course that they never forget the child's died, and they actually want people to remember them. This is an overwhelming feedback that we get. They want people to remember them, and they want people to say the name. And so very deliberately, I used real names in case studies, and families have given us permission to do that. I usually message the families to say that I'm using a presentation, and they're always super grateful that their children are making a difference for their professionals, and so that other families can learn. So it gives me a bit of goosebumps saying that, because I just think it's the precious thing that they've given us. So this is Matthew. Matthew was 15. He actually was diagnosed with DIPG, which is a horrendous brain tumor that children have. It's usually only children. In 2009, prior to that, he'd been diagnosed with this intrinsic lesion in his brain. That had just been really stable, and so he'd had this benign brain tumor for a number of years, and they'd monitored and they'd kept denying it by CT and MRIs, and he'd been very stable. And then in 2019, he had been doing really well, been complaining of occasional headaches, which his mum didn't really worry about, and then a little bit of ataxia, but again, she wasn't too worried because, maybe he was just hiding, kind of like brush things under the carpet. And then one day he was a massive stock up there, and he was going to training, and he stood up to walk on the pitch, and he collapsed. And they took him to the hospital, and they found that he actually had DIPG. So this was in 2019. Usually prognosis for children with DIPG is around really between 12 months to 2 years, but around about 18 months. It's a terrible disease. As you can see from the picture, if you can't see it, it's actually really deep in the brain and on the top of the brainstem, and so they can't remove it. They do offer chemotherapy and sometimes radiotherapy, and I think he had radiotherapy. However, it was always going to be a palliative diagnosis, and so he was referred to the Paediatric Palliative Care Service, which is based in the Queensland Children's Hospital, and then also to Hummingbird House in March 2020. So just to remember as well that this was just at the beginning of COVID, and so we did have some challenges because of that. He was introduced to us. Let me just see what it's on the next screen. So he was introduced to us at the hospice because he was super keen to access hydrotherapy. And at first, his family really said that they didn't want to access the hospice. Hospice care wasn't for them. They lived fairly near the hospice, but it wasn't for them. They were managing really well at home, which was absolutely fine. But they did ask us to go and do a review of him, and to so that he could be on our books, so that he could have hydrotherapy. And so I went to see him, and when I went to see him, he was like this young man that you can see here. This is his sister Keely in the background, and he was fairly smiley, alert, able to speak but very slow, and he had just used the chart where he could spell out words. Throughout the few weeks that we knew him initially before he accessed the hospice properly, that certainly function declined, and so we would say that he was having increasing headaches. His speech really disappeared. He was having difficulty with secretions, and he certainly wasn't able to swallow, but he still would come every week and access, well, actually 2 or 3 times a week, and access our hydrotherapy pool. A big beaming smile on his face. He absolutely loved it. The family then got to know us in the hospice, and what was really helpful, because he was accessing the hydrotherapy pool at least twice a week, I was able to call in, say hi, get to know the family, and I would just sit down by the side of the pool and then we just have a chat. But from that, I could learn how he was with symptoms, how much pain he had, did he have issues with secretions, what were the actual worries, and then the family actually gained trust in the hospice, and I would feed all that information back to his treatment teams with families, of course. So Matty continued to deteriorate, and he did have a hospice stay just to give the family a little bit of a break, and they stayed for a couple of nights, had a great time, and then we went back home again. And then he deteriorated to a point where he was basically unconscious at home, and again they wanted to stay at home. The symptoms that we saw for him were mainly pain, but also dyspnea, and we checked that with morphine, and I just used 7.5 milligrams of morphine. Midazolam, so he had a little bit of agitation. We also used midazolam as second line for dyspnea, and so we could give him that. And kind of he got to do that pre-terminal agitation by the kind of pull at the clothes and the hair and like his belly and in his head, so we were giving him that. Glycopyrrolate, we use glycopyrrolate much more commonly in paediatrics than I have seen in adult pal care. I see from the new things that I'm learning recently, Buscopan is used quite a lot. They don't tend to use Buscopan very much in children at all. I have seen it used kind of in the older, like the young adults, so 18 to 21-year-olds, which is what we are licensed to take, but commonly we use glycopyrrolate. I don't think it's as easy to get as Buscopan. So he had increased secretions, but that worked really very well. And then nausea and vomiting wasn't terrible for him, and then we used ondansetron quite a lot. By the end of his life, he did have a driver, and so he had morphine of 60 milligrams, midazolam 40, and then we had 200 mics of glycopyrrolate. I went to do a home visit. I'd heard that he was deteriorating. He'd had a couple of nurse services going during the day, and then his mum messaged me at 4 o'clock and said, "I'm really worried about Matt, would you come?" And I went. And he was pretty much like he was in this bed, minus the iPad. He was really having kind of changed open breathing. You could hear his respirations. You could hear his secretions when he was breathing. He was having apneas, and he looked pretty shocking, but he was comfortable. And I did say to them that I think he was probably going to die very soon. And then I went to leave, and his mum really, really struggled with that, and said that she was really afraid. So we made the decision to transfer him to the hospice, and he transferred that night. One of the best things that I remember is it was great busy in the hospice. We transferred him, settled him into bed. I tucked him into bed, and then his mum and sister just sat on the lounge suite, and they were going to watch a movie. And so they had a girls' night watching this movie. And then one of our personal care workers said to them, "Have you eaten today?" And of course they hadn't eaten. He said, "Oh, I've got some shepherd's pie. Would you like some?" And so they gave the shepherd's pie and just settled them in. And it's just a lovely memory that I've got, because he was that uncomfortable and they were comfortable and we were looking after them and feeding them. Just to note that this family were from the UK and didn't have any family here, so they didn't have heaps of support, although they did have some community support. So Matthew was admitted with us at about 8 o'clock at night, and then at 5 o'clock the next morning he very sadly died. But his mum, she was asleep and she woke up. She said she heard the change in breathing. She got into bed with him and she gave him a cuddle, and then he died. We were able to then support that family with after death care, and so he stayed with us in the hospice, I think for us for a total of 5 days, and during that time we supported them in logistics of funeral service, because it was at the height of COVID and there was only 10 people that were allowed at the service. We were able to liaise with funeral directors who liaised with the school, and so the school had as he was being taken to to his service, the school had arranged for like a bit of a drive-by, and all his friends were outside with balloons, and this family could see that. So we tried really hard to make it really special for him and for the family, and we played a big British football song as he was leaving the hospice, and that was a really special moment for them. And so after he died, we made contact with his family, and we have continued to do bereavement support. I'll talk a little bit at the end about bereavement support. And his mum sent me this picture. So he was 18, it was his 18th birthday, just in March. And so she sent me this picture, and they had a birthday cake for him. So he died when he was 16. So that was Matthew. I can take questions at the end. The next little baby that I want to talk about is Sophie. So Sophie was first baby of Peter and Brett, second baby of Peter and Brett, and they had another little boy, Jake, and she had Hirschsprung's disease, which is the disease of the gut, of the bowel particularly. And so often what happens when you need to pass a stool, you have little nerve endings all the way along your bowel, and it kind of pushes the stool out. With Hirschsprung's disease, you often have sections of your bowel that miss this. And often they can repair it surgically. Sometimes they can repair it surgically, or we've got another child who had neck at birth, and she's got damaged gut, and she had TPN. She lives quite well on TPN. But with this baby, with Sophie, it was the most extensive case the teams had ever seen. And there was really no options of feeding this baby, and there was no options of surgery. And they were really honest with Brett and Peter and said that she would have a really difficult life, and talked about the options to move on the palliative pathway. That's very difficult because this baby was neurologically well, and so would display behaviours of a normal baby. And I'll just flip to the next slide so we can have a little look. So the aim of the family was, they were a big family, they were a full nuclear family, but had lots of extended families. So both sets of parents had lots of siblings, they had grandparents, they lived quite local to the hospice. The family was a huge thing to them, and so Peter had wanted to take home. She tried to take home, she was discharged from the hospital home, and then was going to have a weekend at home and come to us. But they really struggled with that because Sophie got really hungry and then very distressed, and then that caused Peter to be very distressed. What they did manage to have was they really managed to take the baby to the park that they'd gone to when they'd grown up. All the family gathered and they had this really special afternoon. And then she presented to the hospital, to the hospice, because Sophie was so distressed. So what they wanted from us was, they wanted time as a family, as a nuclear family, and also as a big extended family. And they wanted support with their symptoms. They felt like they couldn't manage this at home, and they wanted space for their grandparents to stay. And the grandparents, particularly Peter's mum and dad, were very, very close. What we saw with baby Sophie, so it's not common in paediatric palliative care that we don't feed children, and certainly even towards end of life, we still will offer feeds, and then eventually it kind of stops. You might offer some gastrite, and then eventually they don't tolerate that. But we're talking kind of really near the end of life, so 2 or 3 days. But we knew with this baby, she had a good heart, her brain was fine, it was a gut that wasn't working. We knew that we would face some challenges. At the time that I've been at the hospice, I've been there 5 years, and we've only had 3 babies that have for various reasons that we've not been able to feed. And all of those have been a challenge because that's a very difficult thing to watch. And recently we had twins in, so we had one well twin and one not well twin, and watching one twin thrive and survive and the other one not being able to feed was really quite difficult for the staff and for the parents, of course. So with Sophie, she had her symptoms at end of life were not at end of life. So her symptoms initially were hunger and distress, and then as she became more and more near the end of her life, that wasn't an issue for her, and we don't believe that she felt hungry. She certainly didn't have any of the normal baby reaction, the root for a bottle and the suck. But at the beginning she did. She also then developed dyspnea towards the end of her life. She became increasingly sleepy. She couldn't swallow anymore. She had increased secretions. Towards the end of her life, she had apneas, and she was one of those babies that had very, very long apneas, sometimes associated with a colour change, and we have to speak to parents about sometimes they'll go very pale or they'll go blue, or you'll see a big colour change. For babies with a darker complexion, often we see darker around the mouth and darker around the eyes. And then, of course, for her, the issue had been significant weight loss. And so from the very beginning, when she was born, she was a chubby bubba. And then by the time she died, she had no subcutaneous fat and she was very thin. So her symptoms, how we managed that. So initially, with the distress of the feeds, we would give morphine and midazolam at those tiny doses, so 0.4 milligrams. Give morphine and midazolam. What I did was ask them, we put her on a driver pretty much straight away. What I did was ask the nursing staff to have those morphine and midazolam drawn up so that as soon as she became distressed, she had any hunger cues, we give her morphine and midazolam. And then our dancer tron, because she did show some signs of being a little bit uncomfortable near the end of her life. Like I said, she had issues with secretion management, and so we used glycopyrrolate 40 micrograms. We still did offer some sucrose on a pacifier, on a dummy, as I call it. I think that might be British, on a pacifier, and a little bit of EBM. And so that was another really tricky thing because her mum was expressing milk. She still had a lot of milk. She was expressing a little bit, so she could give her a little bit of EBM, and that is a really difficult thing as a mum. You have this kind of inbuilt need to feed your child, and so when you can't feed your child, that's a very difficult thing to sit with. And we spent a lot of time with this family. Sophie was in the hospice for 2 weeks, and she died with one of our nurses. Interestingly, she was one of the babies that actually did stop quite suddenly. So she was having fairly prolonged apneas, and then she'd, breathe really quite well. And they were so exhausted that overnight they asked the nursing staff to take the baby, and any signs of distress or we were worried about it, we'd take her back to Peter and Brett. The night that she died, she was with one of our nurses, and she was holding her in her arms, and she was working on the computer, and she was doing neither, and then she looked down and she died. Sophia died. The nurse was absolutely mortified that she hadn't been with her parents, and this caused her an awful lot of distress. However, Peter, being the remarkable woman that she is, actually reframed that and said, "Oh my goodness, Sophie must have trusted you so much that she died with you." And so the nurse took a lot of comfort in that, but Peter really had this special place in her heart for the nurse who had held Sophie as she died. We also provided after-death care for this family, and we kept them in the hospice for, I think they stayed for 5 days as well. We support them with a funeral, and in fact they engaged a funeral director who really did a direct cremation, but our family support manager actually ran that service. So we held the service, all of the family came, and we live streamed it, which at this point was unusual because this was before COVID. So we live streamed it to Peter's work colleagues, and then all the family gathered and they released butterflies, and then Sophie went into the care of the funeral director and was cremated. And again, we provide long-term support to this family. And then I'll show you this slide because I think that's lovely. So Peter and Brett had twins probably about 18 months after Sophie died, and this says handpicked for Earth by our sister in heaven. And so they keep Sophie very much in the forefront of the mind, and actually all the family photos that we take that actually have a photograph of Sophie, take Sophie along. And Peter has talked about how that maybe makes it bit weird, but I just think it makes it pretty wonderful. A big part of what we do at Hummingbird House is after death care. We have a cold suite, and so it's the picture on the bottom left hand side and then the top left hand side. So we have a room, it looks like a bedroom, it's really beautifully decorated, that goes very, very cold. And even in the Queensland summer, and I know we're not tropical Queensland, but even the southeast corner of Queensland, we do get hot and sticky in the summer, but this room keeps the air at about 4 degrees. We use a product called Ice. So instead of using the cuddle mats, because we find them a little bit temperamental and not as portable, we use a product called Ice, which is it comes in flat sheets, and you hydrate it in water, and then it becomes like little squares that you freeze, and then it's actually used for transporting food across Australia, but it actually keeps bodies really cool. And so we could cut it to size for the little babies and then for the older children. So we do after death care a lot at Hummingbird House. What we find is that it gives families space to say goodbye. They don't feel rushed or hurried. There is some evidence, there is a few papers that I've read that talks about the difficulty that particularly mothers have with separating from the child after death. And so the thought of that child going to a funeral, direct them until they're cremated or buried, or going to the hospital mortuary is really difficult for them. And so they're able to have that space at Hummingbird House. If you can see the picture on the bottom, with this was a Aboriginal family, and they did their special rituals. But if you see the little word family, that is actually the size of a coffin of one of our little babies. So we take babies from birth, but obviously we take babies from about 23 weeks gestation. So we sometimes have really little babies in our care, and all the way up to the age of 21. And it's a huge thing that we do at Hummingbird House. And we also can do after death care in children's homes. And we've got a range of techniques for it. There's a lot of words on this, and this is because it was written by our family support worker, and she uses a lot of words, whereas I maybe don't use as many words. But we offer bereavement support. I think what I really wanted to stress was that we don't pathologize grief, that we don't treat grief as a mental illness. We treat grief as a natural, deeply painful loss, of course, but being with, surrendering to, and making meaning of grief. We support families to have strong, continuous bond with their baby and child. Some families grieve best with supportive peers, we've found, and we run bereavement groups, and that can be for grandparents, it can be for families, and we've also just started a peer support. So our bereaved families are then supporting another newly bereaved family, and there's a lot of support around those families. It's been a very extensive project. And then obviously other families do find professional services really helpful, and so some of our families will see psychologists or counsellors, and we've also got a grief counsellor that works for us as well. He does many other things, but that's one of his roles as well. I think as I've rushed through that, but I think I've got time for questions. So I just wanted to say that we're grateful, thanks to the amazing families for allowing us to share their photos and stories, and we remember them and speak the name. And so the children that are listed there are all children who've had photographs that we've used in this particular slide. All right, so now I'm good. And are there any questions? Just take a slurp of tea.
Oh, thank you, Andrea.
Sorry, it felt a bit rushed.
Oh, no, appreciate that you've just rushed in from work and then rushed to present this. And I think for some, they were having hearing difficulties, but I think seeing the pictures, a picture tells 1,000 words, doesn't it? So thank you for the honour that you give to these beautiful families and children that you've cared for, and for just sharing so powerfully about the work that you do at Hummingbird House. Constance has written a comment here saying, thank you, that was an amazing presentation.
Oh, thank you.
Yeah. Did anyone have any questions? We're probably just all in awe of you. And I've worked in the adult palliative care space, and I haven't had a lot to do with dying children, but I do think it takes an extra special sensitivity, because it seems unnatural, doesn't it? When people are in their 90s with advanced dementia and cardiac failure or renal failure, you know, they've lived a good life and it seems natural, but when they're under 18, it just seems unnatural. So coming to terms with that, how did you do that initially?
How do I do that initially?
Yeah, I mean, you obviously got professional boundaries now, but when you first started, it obviously...
Yeah, so when I was a new baby nurse, I started in paediatric oncology because my background is peds. I've always done peds really recently when I've started to branch out into adults, which has been amazing. But I went to paediatric oncology and I learned very quickly, one, that people don't love you to talk about that around a barbecue. You know, if somebody asks you what you do and you say, oh yeah, I work with kids with cancer. Sure, that's a stopper. This is even worse though. Kids who are dying is even worse. Nobody wants to talk about it. But I also learned that I did really need to put in some boundaries for self-protection. So I remember being really quite involved with the families that I worked with as a young nurse, and often they were the same age as me. So it was people my age having babies, and the babies were really sick, and it was really, I really found it hard to detach. And I still think that I support the families really well, but it's not as, I'm not giving my whole self to that because I have to, you know, leave at the end of the day, but I'm very present at the time when I'm with the families. And then, you know, I'm a nurse practitioner and I run the hospice, and you know, it's a very involved, very busy job. But when I leave work and if I'm not on call, I'm try really hard to leave it at work. And I have a really, really supportive husband who's been, you know, we've been together for a very long time, and my kids are really aware of what I do. And little things like, you know, the cliches, but I do try and exercise well, I try and eat well, and try and sleep well, which has been a big issue. But then also the little things like allowing myself to sit on an evening and just watch Netflix and watch trash Netflix, because actually I don't have to think about that. And I'll cry at all those Netflixy stories and things, but it's just a bit of a kind of a break from it. And also I do have clinical supervision. So I have supervision every 6 weeks. I actually speak to another nurse practitioner and we talk through some issues. What I find I bring to supervision is actually not the concerns and sadness that I have over the children that are dying. Funnily enough, I seem to manage that really well, but it's actually the management of the hospice and the management of people that I find more stressful. But sometimes, you know, sometimes it is really sad. And I remember having a boy who had a brain tumor, similar to Maddie, actually. I think he had DIPG. And he was the same age as my son, and my son was 17 at the time. He looked like Aaron, and he you know, played basketball like Aaron, and I found that really quite difficult. And so I had to do a lot of work on, this is not my child, and I'm really sad for him, but I still have to enjoy my child's life as well. I remember doing end of life conversations with this young boy and talking to him about what it is to have resus and what it is to do CPR and having, you know, tube down your throat, and how difficult that was. And he was crying. It was a hard conversation. And then I had to get in my car and drive 20 minutes up the highway to see my son play basketball with all of his friends. And I was like, oh my God, this is what Aidan should be doing. You know, he shouldn't be lying in this hospital bed. And I found that really difficult. But I've got really good people to seek support from, and I'm able to talk about it really quite openly. And then, you know, I did move through that, and I supported that family as he died. And then his dad died really suddenly about a year later, and I supported that family through that as well in my professional capacity. So it's a real honour. I feel like as Hummingbird House, I've got a real gift to give these families, and so I find it a real honour to do the job that I do. That was a bit waffly.
No, thank you. There's a question here from Constance. Do you provide spiritual support at Hummingbird House?
Yes, we do. So Hummingbird House is under the governance of Wesley Mission Queensland, which is a uniting care church. That's kind of their government of uniting care. So we have a I was going to say pastor, that's the wrong one, chaplain. So we have a chaplain. So she will provide the Christian support, I suppose. And then also what they are really good at doing, and also our family support workers are really good at matching families with spiritual supports that they need. And it could be spiritual in the typical sense of, you know, you go to church and you need to have a priest and you need to have a christening, etc. Or it could be they've just a really spiritual presence, and we can work with them with that. We try and link very hard with the local Aboriginal elders, and they have provided us with support for Aboriginal families that we've had, especially those families that want to return to country. That can sometimes be a little bit difficult, but we support that. And then little things like we have got good links, you know, with the local Catholic Church. So if somebody wants to have, I don't think it's called the Last Rites anymore, but it used to be the Last Rites. But if you want to have a Catholic minister, they'll come in. But really, we're linking with our chaplain who has many links elsewhere. So not just the Christian faith, but all faith.
Any other questions? We've got a couple of minutes. If anybody,
I'd like to ask, how many beds is Hummingbird, and do you have a volunteer service?
Yes, yeah. So we have got, so technically Hummingbird House has got 8 beds. We currently are only staffed for, and then therefore we've only got a budget to have you know, between 4 and 6 children at one time, and that definitely depends on acuity. So we can have children who are actively dying. So at the minute in the hospice, we've got 2 babies for after death care, and then, you know, symptom management child in. We've got a child in who's having a respite stay. Last week we had 2 children who were dying. So it really just depends on acuity. So we take between, like I said, 4 and 6. We always prioritise end of life and after death care over everything else, however. The other question was volunteers. Yes, so we have volunteers that do practical things for us. So clean the cars, volunteer drivers. We've got a really big backyard. So we've got the rotary that comes in and cuts the lawns and things. Then we've got volunteers that will work in housekeeping and in the kitchen. And then we've got volunteers that provide care support, and so they will come on shift. So they usually do about 4 hours a shift, and we have them most days, struggling for the weekends, but we try. But they will come on shift, and they will really be directed by the nurse in charge as to whether the siblings might need a little bit of extra support, and they'll read stories or do activities with them, or whether actually the young person or the child needs somebody to sit with them and read stories and do activities. So they kind of work between family and between our children. We call them guests. So we have guests in care. That's very deliberate because they're guests in our house. So yes, we do have volunteers, and really they're the backbone, because really they're just vital to our service, because we only have a limited budget. We don't have enough staff as everywhere else doesn't either. So yeah.
And what areas? So you're based in Brisbane.
Yes.
And it's a children's hospice. So
yes.
Is this the only hospice, children's hospice in the Brisbane area?
So in Australia, there are 3 hospices, one in Sydney, one in Melbourne, and then us in Brisbane. And then the new Perth one is hopefully going to come online in a couple of years. But so yes, so the only one in the whole of Queensland. To put in perspective, the UK, which fits 3 times in the Queensland and some, has 56 children's hospices.
Yeah.
When they've done the projections as how many, you know, for population changes, how many children's hospices does Queensland need, they came out with a figure of about 16. So we are one children's hospice where it should be 16. But we do have a statewide remit. It is very difficult to manage that, but we have children from difficult cares all the way down to the borders. So the most recent child that we had from south of the border was from Nimbin, so it's a really big area. And we have community development workers who link families in, who try to link families into the local communities, because to build capacity, to do compassionate community work, to build capacity to look after families in their own space, which is very important. But we actually do have children who travel down from Rockhampton, Townsville, Mackay, all the way down the coast, Isa, Roma, who will access the hospice, either because the children are in Brisbane and they suddenly deteriorate and they're dying, or mums who are pregnant, like we had a mum from Roma, you know, they did a scan, they realised that the baby wouldn't probably survive after birth, so she moved to Brisbane for the birth of her baby. Baby died, baby came to us for end of life care and then died. We also have children who are accessing the Queensland Children's Hospital, and so instead of having to find accommodation, they'll actually come to the hospice, have surgery or appointments, and then use the hospice as a base, and we could do some symptom management and work with the family. So we try our very best, but it's a very big state. Wow. And the same with the other 2 children's hospices as well. Yeah.
I'm conscious of time. It's 7:02, and we like to keep integrity with time, but I don't want to cut anybody off. I did just want to ask Andrea quickly. I know in previous years, pre-COVID, that Hummingbird House would have an open day on World Hospice Day, which is usually like the first Saturday in October. I know with COVID that hasn't happened, but is that something likely to happen this year?
I don't think so. So we used to have, Brisbane Open House, and we used to have our open house then. But what that meant was closing the hospice down, or closing it as much as we can, and only having 1 or 2 families in it. We're just finding that we're actually not able to close at the minute. We're just so busy
Sure.
with children at end of life, actually. So no, we don't. But what we do definitely offer is, health professionals. I do a lot of talk to nurses and doctors, and we always say if anybody wants to come and have a little look, then we're really happy to share our service, and people can get in touch with us. I'm really happy to show people around. So, but unfortunately we just don't open, we just can't. But we have had groups of groups of midwives from a local hospital have come through, and then doctors from the metabolic service and PICU and all of those places. So
yes, okay.
yeah.
No
And
worries.
if you look on our website, there is actually some really good photos, and on our Facebook page there is our general manager Fiona did a walkthrough one day, so there's other stuff there, and that's what we use to show families if they can't get to the hospital.
Yeah, follow Hummingbird House on Facebook. They post some beautiful stories of families and what they're up to, so that would be great. Well, on behalf of us all, thank you, Andrea. Thank you for an amazing
I'm so sorry I was late.
presentation. Oh, no, don't worry at all. No dramas at all. I think you crammed into 30 minutes. But
I should have done it in an hour.
No, because you can talk so fast. I don't think I can talk that fast, but you did amazing.
I hope you could keep up. Geez, I'm sorry.
All right, we'll go and enjoy some dinner, and thanks everybody. I'll ask Jackie Williams to see if she's available as a death doula for next month. All right, take care.
Right,
Thank you, everybody.
Thank you.
Bye now.
No worries. Bye for now.